Great. It looks like everyone is in from the waiting room. Hi, everyone. I'm James Masinko, part of the seminar committee for CCPR this year. And we're really just thrilled to have Dr. Sanjay Basu with us today. Before I introduce him, I'd like to reiterate some of the ground rules we came up with that seemed to work pretty well last seminar. First, please mute yourselves unless you're talking. Feel free during the presentation to interrupt with your question. For the end of the presentation where we have our discussion, please then just write in the chat, I have a question. I'll keep a list of everyone who has a question, and that way we'll get to everybody in turn. I would also mention that if you're registered, I know there's a couple students registered for the pro seminar, that'll happen right after the discussion at 1:30. If you're not registered for the pro seminar, please log off promptly so we can start that session on time as well. So with that, it's really my pleasure to introduce Dr. Sanjay Basu. He's a physician and epidemiologist. He's director of research at the Harvard Medical School's Center for Primary Care. His work has really been at the forefront of incorporating mathematical modeling with other approaches into prevention and treatment of chronic diseases, reducing the health effects of financial shocks and adverse social determinants of health, and improving access to essential medicines and developing primary healthcare infrastructure. So with that, I'll turn it over to you, Sanjay.
Thank you. It's so nice to be invited here and nice to see so many of you, at least virtually. I'll be talking about some challenges that we've faced in using some simulation models to try to refine COVID testing and COVID triage to some high-risk populations that I'll describe. First of all, just want to check, can everyone see my slides or any problems seeing this? Looks okay? All right. So here is how I'd like to set out some of the conversation, and I'm assuming you'll all interrupt me throughout. This is research in progress. Please critique and suggest, and we'll certainly be happy to incorporate these suggestions and acknowledge you. So thanks in advance for your thoughts and criticisms as we proceed. I'm going to focus on a particular high-risk group of settings in San Francisco, high risk for COVID as well as other forms of morbidity and mortality. I'll describe to you some challenges or problems that we encountered in COVID testing, some of which have been certainly discussed extensively on a national scale, but present some unique challenges in this population as well. And then I'll spend, I think, a majority of my time talking about uncertainties when simulating and how we might navigate and traverse the spectrum between having poor understanding of how to best model a circumstance as new data emerge from a novel disease, for instance, and real world insights as we seek to actually implement some of the results of our models in the form of interventions. So the particular settings that I'll describe are what have been called homeless hotels in San Francisco. They're not really hotels like the Ritz-Carlton or the Marriott, but rather during the course of the beginning of COVID, particularly accelerating in March of this year, it feels like several years ago, but now it's only been several months. San Francisco having about roughly, who knows the real number, but roughly 8,000 plus homeless individuals, so a little over 1% of the city's population, it's thought, decided that in order to reduce the risk of COVID transmission among homeless or marginally housed people, they would undertake sort of 3 sets of interventions. And so this was kind of the layout that we had for us that posed the research questions I'll discuss. The layout was that they would allow homeless or marginally housed people to either be in officially sanctioned encampments. So there's a picture of one in front of City Hall, for instance. You can see a 6-foot separation between tents, and an individual essentially is assigned a parking lot space, more or less, and under certain behavioral rules is permitted to stay there. Or the larger portion of the population was swept largely off the streets by police and put into single room occupancy motels. So these are very tight quartered, typically one person per room, but not always. There are some families or some parent-child dyads, much more rarely a couple, who are put into these single rooms. They don't have a bathroom. Sometimes they have a sink They usually have electrical outlets, and these are in kind of low quality motels that are either converted old apartment buildings that may have not been up to code for residential living, but through whatever arrangements with the city were permitted to serve as a motel and were mostly unoccupied except by folks who were marginally housed and whose rent was either partially or fully paid through city, county, and state funds and some federal funding. So in effect, this created a series of large congregate living facilities with individual rooms, but otherwise congregate areas that were mostly of marginally housed or homeless adults. And part of what we were asked to do in terms of a research project is based on how these are organized. So there were essentially two sets of these homeless hotels, or really SROs, single room occupancies. The first set were for people who had no symptoms of COVID or had not tested positive. Many of them didn't have a COVID test, but who were not suspected to have COVID and were essentially sheltering in place. That's what the SIP is. Others were people who were either isolated or quarantined due to either symptoms and were awaiting a test result, or had a positive test result. And there were a limited number of also trailers that were put very far in the southeast corner of the city, essentially parked RVs that were used as overflow from these motels. A few of these sites did remain, at least early on, as what we would traditionally think of as homeless shelters, so really congregate facilities. But the majority of people were moved into these single room occupancy motels. And what we understood at the time, we're given a little bit of information in terms of the demographics and background of these folks. We were among the sheltering in place population, those presumed to not have COVID. There was a bit of older age predominance as compared to our overall city's demographics. There was a larger portion of Latino and Black population, and a little bit more male than female, although a large portion of people did not respond to that question. Among those who were confirmed as COVID positive or were awaiting a COVID test and were suspected to have COVID and were waiting results, we again had a profound inequitable Latino population representation, and as is more true nationally, a male predominance. So here are the set of research questions that we had in this context. So a little bit about who we were. We means there was a group of community-based case management and primary care agencies. They're essentially contractors with the city. There's two of them, the one I work for and another one, that essentially provide primary care services to marginally housed adults on behalf of the city and county's Department of Public Health, and on behalf of the mayor's office and others who fund primary care in the city and through public facilities. And so we were essentially assigned as a groups of physicians, epidemiologists, nurses, social workers, and so on, to manage healthcare in these homeless hotels. It was essentially a room service medicine approach where we walk through each day, knock on doors, and the full spectrum of imaginable outcomes occurs. Everything from somebody is sitting there fine to dead after we open the room door. And within the spectrum of what was happening, there were several key questions that were, I think, appropriate for research that needed to be resolved. One is who to test, given the, as you've no doubt heard, the limited supply of both testing equipment and moreover, the back-end labs being overwhelmed. There were several choices here. There was enough testing swabs and supplies and laboratory availability that we knew we could test beyond those who were symptomatic. And early on, of course, there were several reports indicating that a large portion of infectious people were likely asymptomatic or minimally symptomatic, but still infectious. And so the question was among them, how often to test and whom to test. We early on also discovered, or realized rather, that a single laboratory was not going to be feasible to really test a large number of people. And so there was the task of creating a testing network, several laboratories that would be available, but needed to have us distribute the test somehow among them in order to optimize, as kind of an operations research problem, minimize the waiting time, maximize the proportion of people getting results within a clinically meaningful window, meaning generally less than 72 hours, for it to be helpful for contact tracing and isolation in time that others would not get infected who are nearby. And just to contextualize this, I know a lot has happened since these months, but this is also at a time even prior to the first CDC testing guidance. It's hard to remember back then, but at that time, the CDC hadn't even had a suggested um, testing approach. And soon after that did have an approach for people who had symptoms and exposure, but didn't have an asymptomatic approach. And then several months later did have an approach for asymptomatic individuals, largely who had been exposed, but didn't answer questions like how often should one be tested in order to do asymptomatic surveillance testing. Even today, it remains a subject of uncertainty. Nevertheless, our city's Department of Public Health and others suggested that we test people about once a month. And when asked about why that particular number, it just seemed like a good round number. There wasn't a lot to it. And so the asymptomatic testing idea would be, let's stratify the population in terms of risk as one potential option, and do asymptomatic testing, let's say weekly for some people who are very high risk. And if they also have symptoms, they get an additional on-demand test. Those who would be monthly would be similar monthly testing, and then an additional on-demand test if symptomatic or exposed. And so is this the right approach? What is the right cadence of testing? And what are the risks of getting it wrong? What are the implications in this context? And how can one recover from getting it wrong when you have a whole hotel or motel full of people who may be at quite high risk for complications? So a few practical points before I describe how we approach this research problem. One point was, as we were initially presented with this problem, our first thought was that somebody else has probably solved this already. And so we went directly to the lab network, to the departments of public health, and asked them how they approached this dilemma. And we were not pleasantly surprised with the result. When discussing both with individual labs as well as with their network partners, distributors, people who consolidate labs, or wholesalers of lab supply, we found that essentially the planning activities were limited to an Excel spreadsheet that did at most a linear regression of demand for the past week and then projected it forward. And I'll talk about why that may not be the best approach. And certainly among the departments of public health, we also saw similarly a fairly limited set of planning around how one would respond in terms of the cadence of testing. What was driving the decisions around recommendations was largely logistical, or what was thought to be practically feasible within a given staffing scenario, which is understandable, but not actually driven by, for example, the desire to prevent an outbreak on site or to understand how to most cost effectively distribute resources to a given site. So what we desired is initially to improve upon a basic model in which simply the last 7 days of demand for testing was projected linearly forward, and then supplies were ordered for the next 7 days. And what we wanted to imbue in our approach was an understanding of the transmission dynamics of the infection, some of the logistical constraints, the queuing nature of the problem, the operations nature of the problem of how to send different labs, different supplies, and also the implications of the problem from a social perspective of what was happening among the population that had been moved to these motels and their degree of risk. So one additional complexity before I talk about our model is it was important to recognize two constraints within our system. One constraint was that not all tests are interchangeable or sendable to each laboratory. There are a number of laboratories out there, the city laboratories, the local hospital laboratories, commercial labs like LabCorp or Quest, and some state laboratories, all of which were fairly overwhelmed. But what we would practically be faced with is be sent a box of swabs and a box of transport media, and each hotel or motel would have its own set of boxes, and those would not be interchangeable to every lab. Some labs wouldn't accept some sample types, and others would have their own special cartridge types. And so complicating the matter is the lack of interoperability among the labs. The second, and important from an epidemiologic perspective, is that among the test types, even within test types, there was a wide range of sensitivity and specificity, meaning the ability of the test to detect true positive people and the likelihood that the test would not indicate infection among someone who truly didn't have it. And of course, at the time, if you recall, there were a lot of antibody tests on the market, despite the duration of immunity and the quality of those tests being limited. But we focused really on trying to identify active infection. And at the time, that was predominantly a PCR-based nasal swab. But even among the PCR-based nasal swabs, you can see the level of detection varies tremendously by more than 10 or 100-fold, such that one PCR can detect in that transport media of the nasal swab only 40 copies of virus. And yet another one, this one being used, for example, in LA school districts currently, requires 100,000 copies of the virus per milliliter before it detects it as a positive. So that's a profound amount of variation. And to say, we're doing PCR testing, therefore, is itself perhaps an oversimplification, when PCR testing could range from exquisitely sensitive with its own implications for specificity to highly insensitive with its own implications for the risk of missing an infectious person. So how do we deal with these constraints, and how do we approach it? Here's where I'll start to set out our approach, and would love your critique and interruptions as we talk about the different choices we made and the wisdom or lack of wisdom in those choices, how we might think about it in retrospect, and how we would improve upon it if we had the opportunity again. We divided our approach into three groups of issues or uncertainties that we were faced with. Of incubation before infectiousness, infectiousness before and after symptoms, duration of symptomatology among people, and can we understand this particularly worrisome subgroup of people, colloquially called super spreaders, who may have, for whatever reasons we still don't understand, a profound degree of viral transmission or other properties that may make them likely to transmit the disease? Is that purely due to their circumstances, or is that a biologic phenomenon? So those are all I would classify under the natural history of disease, understanding how we would model the disease process itself and its transmission. The second has to do with the uniquenesses of these sites that we're studying. There's a lot to be concerned with, and I believe there's some sociologists and anthropologists and economists and other social scientists on the line who would know better than I. But I take it as an assumption and not necessarily a given that taking people off the streets who are homeless and putting them into these motels is assumed to actually improve the situation. Certainly as a physician and in terms of a humanist perspective, providing housing is one thing. It's another thing to see the dynamics of what takes place here. Here are a group of people who are transient or have some sort of semi-fixed housing in tents or tarps under bridges or even in bridges. In San Francisco, there's often a lot of living taking place in tunnels and in the baseboards underneath elevated highways. And so during these police sweeps, at least as I and others have witnessed it, essentially it's a sweep of people who are forced out of that condition, whose belongings are mostly trashed. and who are told either go to prison for the night, or jail rather, city jail, or go into this room. And they're provided 3 meals a day that are pretty basic and unsavory, and a congregate bathroom. What does that imply for the transmission dynamics of disease? These are generally ventilated in a wide range of different ways. The congregate bathroom is certainly a site of concern. And it kind of reminds me of when you're in college physics and you're trying to do the proof, how there's so many assumptions about how behavior is going to take place here. These are people who are just told, shelter in place at this site. This is your room for now, for the next several months to a year. But it's kind of like, assume a frictionless sphere on a perfect plane and the subsequent lemmas will follow. Of course, naturally, these people did not simply just shelter in place and stay isolated in a room for 24 hours a day, except for going to the bathroom and opening their door for meals. People disappeared, other people appeared. There was a lot of substance abuse going on at the sites. People were, of course, socially mixing. There were police on the lobby or first floor, and then people could be seen entering through the fire escapes and through the roofs. And so there's the normal dynamics of humanity. What does that imply for COVID transmission and for taking care of folks in this site from a healthcare perspective? And the third set was the unique constraints that we had in terms of laboratories. So here we have a range of labs, commercial, public. They each have different capabilities and they're each doing different tests. Each of those different tests have their own properties: sensitivity, specificity, turnaround time, which swabs they'll accept or not accept. And so they have different functional capabilities, and here we have to somehow optimize both how and how often we do the testing and how we would send it in this demand management framework that, frankly, I as an epidemiologist was not comfortable with. I ended up learning a lot from colleagues who do grocery store logistics management, because it strikes me as similar to the problems that Trader Joe's has in stocking the shelves and getting amongst all these different entities the right supply and demand balance than what we would typically think of as a standard epidemiologic problem. So let me describe and get your critique. Again, feel free to interrupt. As I describe how we approached each of these particular problems, these 3 problems in STEP. So first was the natural history of the disease. There are a wide variety of disease simulation approaches out there, and
Hi, could I am interrupting, but perhaps not exactly germanely. This is Don Tryman. I'm a sociologist.
Hi.
And before you get into your discussion, I am curious, based on your expertise and experience, as to whether you think that the kind of routine screening that, say, a health center would do, where they take your temperature and ask you, have you ever been exposed to COVID in the last 2 weeks, and do you have any symptoms? Okay, no, go ahead. Whether you think that has any value at all.
From my reading of the literature, it has some value, but not much. And I'll show you some estimates of the degree to which we might think it would prevent secondary transmission. And our estimates typically center around maybe a third of transmissions being preventable if everyone is correctly answering and everyone is correctly performing temperature screening, symptom and exposure screening. And that's based on 3 factors. One is the proportion of people who don't have an elevated temperature. 2 is the proportion of people who are asymptomatic or so minimally symptomatic that they consider themselves asymptomatic. And then the third is the proportion of people who don't know that they've been exposed to a positive case. But that's probably also an optimistic answer, because at least in seeing how people do temperature scanners, which humorously for me have been renamed thermal scanners. I don't know why. I guess it sounds a lot cooler and more precise if you call it a thermal scanner than a forehead thermometer. But just seeing just the sheer miscalibration, even in a health clinic, honestly, I go into clinics and people say, oh, you're 96. If I'm 96, please call an ambulance. But, clearly something's wrong with your temperature taking. And of course, there's, as you know better than I, many incentives to not report correctly. So that may be even the 1/3 might be even optimistic.
Thank you.
Yeah. And that sort of reinforced for us the desire to try to figure out the testing component of this for these sites, especially as the rumor mill and discussion mill among these patients certainly, understandably, was one of great fear of being sent to the positive hotel or the positive motel. You can imagine there's incentives to not want to be around in the isolation or quarantine hotel. So the likelihood of correctly reporting symptoms or exposure is also diminished there. So in terms of simulating the natural history of disease, a lot of factors that were just discussed have in terms that are relevant for testing and determining how often to test, how much to test, who to test, are dependent on understanding a bit about what assumptions or understandings we would want to incorporate in to simulating what the impact of testing would be. And that, of course, depends on questions like how many people are asymptomatic, how many people are infectious while asymptomatic and not. A very classical way of simulating this, as many of you are probably familiar, is a so-called Kermack-McKendrick model from, I believe, the early 1920s, sometimes called an SIR model or susceptible, infected, and recovered model. This essentially treats disease, and is certainly not the only way. I'll show a couple alternatives. This essentially treats infectious disease processes the way an engineer might think of people flowing through different states. You can think of fluid flowing from one sink of susceptible people upon infection, going down the drain to a sink of infected people, and then going down the sink to recovered people. And was initially used to simulate measles, and then subsequently many other infectious diseases. And one of the advantages of this modeling type is that it can inherently incorporate how the rates of flow between one state of to another depend on how many infectious people are around you. That first parameter, that sink going from susceptible to another state, in this case exposed, a temporary incubation period before becoming infectious, either a subclinical, meaning not symptomatic, or clinical, meaning symptomatic infection, and progressing from there to later stages of disease, which are believed to be more infectious, and then to recovered immune state, which most people so far seem to at least embody for 3 months, although there have been reports of reinfections. This initial parameter can be made dependent on how many infectious people are around and what is the rate of contact, and then what is the rate of probability that contact results in an infection. And so that captures or can capture some of the nonlinearity in what we see in infection curves, the fact that it's not a constant rate of infection, but accelerates and blossoms the more infectious people are around to infect the susceptibles. And I'll show you some of the depictions of that nonlinearity. Of course, there are several disadvantages to this modeling type. One is the more complexities one wants to incorporate, the more states you have to create, and the more rates of flow between states you have to estimate, and it can be hard to estimate those. It's one thing to say, how long till you recover? You have studies showing very frequent viral load testing until a person has clinically recovered, and then you can estimate how long it takes. But estimating the number of asymptomatic people or the proportion of asymptomatic people can be challenging, requires very wide population-wide surveys. And so few of these have been done in the United States. A lot of them are based on either natural or unfortunately natural circumstances, cruise ship infections, for example, or from more comprehensive studies that have been done elsewhere, studies of whole populations tested over time, such as in Iceland and portions of Spain. Another challenge of this is that it simulates the disease process through a series of differential equations. What is the rate of change, ds dt, a rate of change of susceptible people as the infection occurs? That makes it mathematically convenient. One can derive explicit solutions, but at the same time, it also treats that group as being homogeneous within. And so if you want to capture heterogeneity and susceptibility, for example, you have to create many susceptible classes. And what should define those classes? There's a choice. Should it be your diabetes status, since we believe diabetes mellitus has something to do with susceptibility? Should it be a social status? Should it be a combination of multiple such covariates? And quickly, you've made a more complicated model and had to decide what the degree of complexity should be. And I'll talk a little bit about some of the uncertainties and dilemmas presented by this approach to modeling. Let me dissect. Sorry, go for it.
Professor Basu, just a quick side note. I'm getting some messages in the chat that there seems to be a slight scratching sound coming from the microphone.
Sorry, didn't shave well enough, I guess, this morning. Let me try to readjust my.
Thank you.
Is that better?
Yes, it sounds a little bit better.
So let me try to dissect this infection rate parameter, this conventionally called lambda, the rate of infection a bit more. How might we understand it in this context? And here's where we see how, with these simulations, some of the assumptions can quickly multiply and be consequential. And we can think about what some alternatives might be and what their implications could be. So again, sort of starting in the 1920s, but really progressing in the 50s, a degree of an approach rather of simulating infection in airborne or droplet settings was created by these two scientists, Wells and Riley, again from more of an engineering background, and who conceptualized this using kind of a Poisson distributed assumption. They had worked with colleagues who effectively had chambers of guinea pigs and would introduce an infected guinea pig with a particular, in this case, a bacterium, a TB-like bacterium, and then would see over time how many other guinea pigs who were susceptible would be infected, and how that depended on the ventilation rates of the room, of the pulmonary ventilation rate, essentially how much intake of air each guinea pig had, and then generalize it to unfortunate natural experiments that occurred among humans, such as nosocomial transmission, congregate people on a hospital ward and transmission among hospital patients of an infection, for example. In this case, it's assumed that the probability of infection is kind of Poisson distributed with the number of people doing the infecting, with a bizarre variable called the quanta generation rate. And I'll come back to this one. It's essentially how much infectious particles is an infected person spewing out. With the pulmonary ventilation rate of a person, their time of exposure, and proportional to room ventilation rate. Room ventilation is easier to measure with some handheld vent meters. Now, the quanta is the most, it almost reminds me of humors. How do we quantify the number of quanta? Is it viruses? Presumably not, because it's not simply one virus. Thankfully, it's not just one virus that's needed to infect a typical person, but a load of viruses. Often infectious disease epidemiologists will refer to ID50, the load of infectious product, viruses, bacteria, fungus, that is required to infect about half of susceptible people. In this case, quanta has to be kind of empirically fitted to, again, unfortunate natural experiments. For example, places where we know the ventilation rate well, because it might be controlled, we know how long a person was exposed, and we know the exact arrangements of the infected and susceptible people. And so airplanes are a very good example of that. Another location is, unfortunately, one of the homeless shelters in San Francisco had a very well cataloged in post hoc transmission where we understood the vent rates, and in retrospect knew that there was an infectious person and saw the rates of effectively infectious COVID quanta in that setting. And so this is a fitted parameter, and that presents the dilemma of having to repeatedly sample from distribution of how much different quanta people might emit. Now we have super spreaders as well, so a long right tail of the distribution, and therefore we have this similar problem that we often have when we have long right tails of the distribution. Those right tails are poorly characterized, but often very consequential. And so I'll come back to that issue in a moment as we think about this. So this is essentially the set of assumptions and formulations built into that lambda, that parameter of how much people are getting infected and entering into the incubation state before becoming infectious in our simulation. Any questions or concerns about this? The other parameters in our natural history are better understood more through serial tracing studies of how much people who were detected to be infected, how their natural history of disease evolves. Typically, we have a period early on when the viral load is building up in a person's system before the PCR test that we were using could become positive, depending on a threshold, their limit of detection, which, as I showed you, was widely varied by test. And then often they'll develop antibodies, although we're learning more and more about how asymptomatic people may develop fewer antibodies than others. And their period of really infectiousness, meaning they're spewing live virus from the respiratory tract, is not necessarily perfectly correspondent to the period in which the PCR is positive. Their test may be positive for a much longer duration than they are infectious. That's one of the reasons for current guidelines suggesting that a person not need to test negative before returning to a workplace or a congregate location, because dead virus in the nose can still produce a PCR positive for a duration of time. And so it's just considered that one needs to wait for 10 days or so and be minimally symptomatic before return. But that poses a problem for our modeling. If we're detecting people who are positive and putting them in the quarantine and isolation facility, we may be catching them too late and they've already infected others in their motel. If we're assuming a negative test corresponds to lack of infectiousness, we may additionally be wrong. They may just be in the period of incubation in which they are already starting to be infectious. By some estimates, it could peak infectiousness maybe a few days before symptomatology. But we're assuming they're free and clear, and we won't repeat detection until they're either symptomatic or they get their next scheduled test whenever we decide that to be. So a few dilemmas that need to be taken into account so that we're not assuming testing and truth are the same thing. The second element that was a challenge for us is the mixing dynamic of sites. And I'm very curious to hear my social science colleagues and suggestions about how we might better study this. Here's how we chose to model it. We chose to have kind of a generic model in which we had residents, people staying within the site, and then workers and public. There was a limited amount of public, mostly workers who were everything from social workers to clinicians to police officers going back and forth into these motels to deliver services. And we essentially had a group of people who simply observed how much do they mix with each other, in what location, with what ventilation rate, with what properties of the mixing, that is how many people together of each type, and for how long. And kind of came up with a social contact matrix amongst these groups. Now, we didn't know with precision how much each type of contact risked the probability of transmission of disease, but could observe simply the duration of contact and the degree of contact and the types of rooms in which the contact occurred. But we quickly noted that one of our assumptions was probably wrong, and that is the assumption that residents stay in place. People would disappear and reappear. Other people who weren't residents and members of the public would appear and get past the police presence on the first floor. And so that complicated this and may very well be relevant to understanding. But at least in the simplest model that we started with, this is how we had simulated the social dynamics of the site as just a simple contact matrix with one group of non-movers and two groups of movers interacting with a more general community blob. And that blob would have just whatever the rate of average infection in the community was at the time, to simplify it for ourselves.
Is there a way, Don Tryman again, is there a way to assess the rate at which residents are violating the not moving back and forth condition? And I was thinking about something that people might or might not tolerate, but something like an ankle bracelet or some other device that actually records whether they're in place or whether they're out and about wandering around, as some way of getting a handle on the extent to which your assumption about residence is correct.
Mhm. We had a couple of options to us. So one was, despite these being marginally housed folks, almost all of them did have smartphones. And we did have access to Google Apple mobility data that gave us a sense of how far people would travel. And we, of course, knew the dimensions of rooms and what would typically be near term. Now, on a congregate level, of course, Google and Apple doesn't give us individual people's mobility data, but at a congregate basis among certain facilities, we could get a rough estimate of how far people are traveling, not necessarily where, but how far of a radius they were traveling. Based on that, and many individuals were traveling well beyond what would be reasonable to assume was within the confines of going from your room to the bathroom and back. The other option, there was security on the first floors, but there were plenty of people kind of going out the fire escape or across the roofs. And so simply tracking based on the security presence on the first floor was probably not very accurate. But eventually, because this is a whole separate discussion we could have, because of the sheer number of overdoses that we faced, we started realizing that as much as we were occupied mentally with COVID, we were having such a profound amount of opiate overdose and other substance abuse overdose that we really had to have a strong amount of Narcan available and some trainings and so on for residents and the use of Narcan. And we started installing sharps containers in the hallways and other things. In that setting, there were hall monitors who were there not to really stop people in order to avoid altercations, but who had some sense of where people were moving around. And they were more from like a community case management or charity groups. And so in polling them, we got a sense of how much this model assumption was wrong, and it was likely very wrong, with typically on average like a 14-person hallway, at least 5 to 7 people leaving for long durations of the day through one means or another that avoided the police presence on the first floor. And a lot of that, of course, related to the substance use and the intoxication that we observed. So in later iterations of the model, we decided to build that in, but the question is what, the degree of self-selection. Are the residents who are leaving the ones who are most likely to get, more likely susceptible disproportionately to COVID for one reason? They're certainly probably more likely to get it from community than those who are staying there, but we're not entirely convinced that the COVID risk within the motels is less than in the general community. So in modeling some of the interventions, here are some of the other interventions we took into account. One of the greatest uncertainties that we had in the simulations was what other people were doing in addition to testing. If we simulated simply testing in isolation, it wouldn't account for all the other multiple measures that were taking place. And there were a few studies that took place that we're trying to make use of a sort of natural experiment setting, but this was not really a nice natural experiment because in our setting, multiple things were being done at the same time. In bold, here are the things that pretty much every site was doing. And then the not bold, there were additional things that were being done at some sites. So we had a very contaminated situation where everyone was throwing every intervention into the pool at the same time, and that's understandable. But the real challenge from a modeling perspective is estimating what then is the impact of these individually and in combination. If one assumed it was simply additive, that would be great. We'd have more than 100% effectiveness, but naturally that's not the case. So how do we simulate combinations of these things, of these interventions? And what degree of literature do we have to support them? I'll get back to that problem in a moment as I describe the third component of the model, because those two components kind of interact with each other to produce a dilemma that we tried to solve in a particular way. So the third component of the model was the laboratory testing network. And here's where I learned more from my operations research colleagues in terms of queuing theory. Here we have, if one can imagine that there is a queue of patients, a line of patients who are awaiting results of a test. We're not very limited in doing the testing physically. We're limited in the laboratory portion of getting back a result. And they default from the system either due to death from all-cause mortality, or default from the system, people would up and disappear from the motel for any variety of reasons. We had, in our first stage, kind of done a simple kind of Poisson type model where we simulated what is the proportion dropping out if you have a given waiting time. Let's assume kind of an exponential decay on the proportion who drop out rather than receive results. And then we say, let's have a group of people who enter the queue and who exit the queue by getting a test result. So a good means of exit, sigma, rather than a bad means of exit, delta, which would be the latter being for mortality or disappearance. If that's the case, then we can define a fraction of patients who receive those results. That's a good thing. And so if these quantities are equal, we can estimate a waiting time under this exponential distribution assumption, a big assumption. And so what we chose to do is, and initially we were just running with a kind of a free-for-all disorganized system in which as people were swabbed, we sent it to whichever lab would accept the swab based on kind of the decision of the clinician at the time, and then converted to an approach where this queuing system would be set up for each lab, and we would compute at the beginning of each day which proportion of swabs we would send to each different laboratory in the contracted network to minimize the objective function, which would be the sum of the waiting times. So I'm curious if you all might come up with alternative queuing systems or more sophisticated queuing systems, but this was a simple one that we derived for the particular circumstance and limitations that we had. The second component we built, and the final component of the model we built, was to try to understand how might our estimates differ if we deviated from the SIR type model, not this kind of buckets and flow between states model, but at least one other approach to modeling the potential implications of testing in this population. And the approach we used as a kind of a second model to see how similar or different the two modeling approaches would be was a branching process model. A branching process model being depicted in this illustration here, one infectious person will infect a certain number of secondary cases. On average, that would be the reproductive number, or R. And then each of those would potentially lead to subsequent waves of infection. Some of those infected may not infect others, and so the transmission stops. And of course, we want to understand what we need to do in order to have all of those waves stop, rather than having propagation into further generations of the infections and for the propagation of an overall outbreak or epidemic. And so in a classical approach to these branching process simulations, one would define two possible outcomes: emergence of the disease or extinction. Extinction being that in the near term, arbitrarily defined, the waves of infection would stop. Emergence being that they would be expected to, on average, continue and propagate and expand into further generations of infection. So we derived a simple Poisson distributed approach. I'll refer you to this PNAS model where we describe a more generalized approach that I think is wiser, that can deal with any moment generating function or distribution, and which may be particularly suitable when we understand more about those super spreaders and that long right tail, which doesn't particularly follow a Poisson type distribution. But in this case, suppose you get J secondary cases by each primary infectious person. So in this first wave, J is 3. we'd like to understand this probability of extinction. Well, that's the chance that if you infect one person, how many secondary cases does that one person produce? Plus, if you infect two, how many secondary cases does that second person produce? Plus, if you infect three, how many secondary cases does three each produce? And so on across all possible j through this Poisson-based assumption. And because we use this Poisson assumption, we can simplify through the Poisson expression what this means in terms of the reproductive number R, the average number of secondary cases for each primary case. Here I'm not using R naught, but rather the effective R, because R naught I think of as in a fully susceptible population without intervention. And here I'm using effective R to mean in a population where some people might have been infected and immune, there are interventions going on, it's whatever is actually observed in the population. And simplifying a bit, we can solve then for the probability of loss. We have the probability of loss on both sides of the equation, and so we have to find a root to this equation in terms of the reproductive number. And so in this type of model, what the chances of either propagating an outbreak at one of these motels or letting a case naturally die out and not produce an outbreak is highly dependent on whatever we assume the reproductive number to be. Is this then still a helpful model? Because if we already have the reproductive number, is it adding value? Well, here's what we saw in terms of initial results. And despite the uncertainties, we started to understand that perhaps even this highly uncertain model was helping us bound our expectations of what guidelines might be able to produce in terms of what guidance we had, and helped us question some of the assumptions. It didn't necessarily lead to one profound, wonderful answer, but it helped us eliminate some strategies we had considered that we started to understand would be unlikely to be helpful. The first strategy that we started to eliminate through these models was the idea that monthly asymptomatic testing would be profoundly helpful to us. Even under a wide range of possible reproductive numbers, we found that with monthly testing, we were unlikely to get an effective R that was below 1 as needed for the outbreak. And in the emergence simulation, we essentially continued to have very high probabilities of an outbreak when we did asymptomatic testing monthly, which had been the favored cadence. Although we don't know exactly what degree of testing we'd need, it seemed to be much more frequent than what had been anticipated. And so this immediately concerned us. One common way of showing how different scenarios in these models may impact upon an overall epidemic is by plotting the percent of people infected over the course of a simulation. Here simulating a full hotel and a single person entering and infecting others, against the percent of simulations where more than that given percent are infected. And so here we have two different dimensions that we're trying to consider. One is how often do we test? And the second is interrelated, which is how quickly are we going to get the results? And of course, those are interrelated in part because although we're not the only people placing demand on the laboratory network, if we test very frequently, the turnaround time would typically, if we went from about semi-weekly to daily, the turnaround time would increase by about 2 days because we've exerted more demand on the lab. And so we have a potential perversity or optimization problem here of wanting to balance how quickly we get results with how frequently we want to test and wanting to see which approach is more appropriate. Should we test very frequently knowing we'll get results in a delayed manner and the implications thereof of secondary infections? Should we be more judicious? Test less frequently knowing we'll miss more people that way, but because of rapid turnaround, the subsequent implications of secondary infections on the model are more important. In general, when viewing it this way, of course, the scenario we couldn't achieve was the best scenario, which is daily testing with a 1-day turnaround time. I'm sad to report that 8 months later, still not achieved. But in general, we found that in this type of modeling that testing more frequently was a bit more important than turnaround time. But let me come back to that conclusion because as I'll show you, some uncertainties started to question that initial result. Here's another way to look at it. Here we have daily, semi-weekly, and weekly testing. We even omitted monthly testing from this graph because it was so poor circumstance that wasn't really informative for us. And typically, we'd have like a 3-day turnaround time from daily testing, and it would we'd have typically a 3-day turnaround time from semi-weekly testing, and it would turn to about 5 days from daily testing because of the added load on the labs. So we're kind of seeing that testing slightly less frequently, but with a rapid turnaround time might be a better choice for us. This is the same kind of result, but put in terms of individual infection probability from the model. If we do serial runs of the model, sampling from the distributions of the input parameters, what is the probability of a given individual in the model for being infected? One sees that kind of analogous result. But in fact, once we started taking into account uncertainties around our input parameters, that result started to not be quite so confident. If you can see here, for example, quite a bit of overlap in the distribution upon repeated simulation, with simulations having resampling, Monte Carlo sampling with replacement from the uncertainty distribution of the input parameters. It's effectively overlapping with its comparator. And the same was true when comparing other situations where the frequency of testing versus the turnaround time were comparable. So our degree of confidence went down substantially when dealing with uncertainty in the model. Nevertheless, we learned other important things from the modeling that were unexpected. For example, let's focus on the worker population, the group of people who were nurses, social workers, meal preparers, police, others who were going in and out from the motels. We had what looked initially like a bizarre result. The more testing we would do, the more reduction we'd have in infectious work days. That part's not bizarre. But then we got this weird hump, and then it went off into a limit state. The limit state or a steady state point was less surprising. Of course, if you're testing beyond the point at which you're detecting many infections, you're sort of always detecting the minimal amount of infections within a wide cadence. But this part I thought was totally weird. Why isn't this just a nice curve downwards? And what is this dip and increase? Why on earth, if we test as frequently as every week, would you get more reduction? Why on earth would you get a better outcome from testing as infrequently as like 13 days, for instance, as you would for like around every 6 or 7 days? And what we found here was an interesting interaction and a way to have the model teach us the unexpected, and taking into account the rates of movement into and out of the hotel and the shifts of movement among workers, we found that there was an interplay between the frequency of testing of people, since we were testing workers as well as residents, and the work shifts of those individuals. That if we were essentially out of sync between the testing cadence and the work shift cadence, because of the way different workers were on weekdays versus weekends, we'd have a perfect storm in which a certain degree of testing would actually be worse than less frequent testing. We'd essentially be missing workers, both sets of workers, perfectly, like perfectly missing those who'd been infectious for a while and then we didn't contact trace them because we missed them on the testing cadence, perfectly missing the next set because they wouldn't get tested and the next shift would be on before the testing cadence would call for another round of asymptomatic testing. And so there was an interplay between work shifts and testing cadence that we needed to take into account. One of the more encouraging results we did get, and this is purely pre-post rather than causal inference, was when we shifted from a kind of free-for-all system of sending swabs to labs to a system based on recommendations of the queuing model. So each morning we'd run the queuing model and indicate, here's a box of swabs to send to LabCorp, here's a box to send to Quest, here's a box to send to SFDPH, and here's how to organize to minimize the objective function of sum of all waiting times. Before, our waiting time distribution was such that almost half of our tests were over 3 days. And this is considered clinically meaningless testing at this point because our contact tracing became so poor and the duration of exposure of susceptible people had become so high in that Wells-Riley equation that getting the positive test result by that time was not particularly helpful. It had such diminishing returns, I would say. After our queuing system, again, was it the queuing system or other things going on, improvements in laboratory capacity, for example, and other changes taking place? I can't say for sure because we didn't have a control group. But we did at least improve on our typical days of waiting and the number of people receiving results within a window that was considered clinically meaningful for us. Excuse me. The other informative result that we were looking at from our models was around going back to, I think it was Donald's question around the relative degrees of inference, the relative degrees of interventions and how much we might expect having a population level impact from these. And using our branching process model, we input results from the have been called sort of real-time meta-analyses. As new COVID papers come in, we update our meta-analytic estimates of the impact of these on secondary transmissions in our model. And what we found was the typical set that was being used in the motels initially left quite a large probability of a site outbreak. When temperature screening and using the CDC symptom screener was added, we didn't see such a profound decrease in our estimates, in part because of the asymptomatic folks and in part because of how many people were not febrile. With our reactive testing just being with symptoms or exposure, we did get some reduction, but really with routine surveillance at the optimized point in the model, we estimated the most degree of reduction in a site outbreak. And we can't independently validate this model. So this is one of the dilemmas of the branching process model is, how do we establish that it's true you would get a 2% outbreak site? We only have a certain number of motels and we're all going to have interventions across all of them. So it's more challenging to outbreak than the SIR type simulation model where we could determine the degree of concordance between the model estimated incidence and observed incidence over time. But nevertheless, this helped relay to supervisors and others about our beliefs and our degree of assumptions and what impact we might have at the site. We ended up not having any, to date, knock on wood, outbreaks at the motels so far, up to this point in time. So in terms of the initial set of key findings, here's where we were, here's what we were thinking in terms of our initial conclusions. The first was that we had to recalibrate our assumptions on the frequency of asymptomatic testing. We needed to do much more frequent testing that had been previously recommended or even thought of at these sites. Secondly, that there was an interplay between interventions or situations, one being shift work and optimal testing time. We had to be careful that our cadence of retesting didn't interact with who we would miss due to the way that workers were on different shifts. We felt like optimization was at least possible, or at least improving the circumstances of waiting times was possible across the lab network. And we thought we had to do something about this interplay between testing frequency and turnaround time and find a balance. But that there was a lot of uncertainty still remaining about whether we would test more frequently and sacrifice turnaround time or vice versa. Ultimately, what we ended up doing was, again, limited by practicality, testing every 3 days rather than daily, simply because of the supply chain of swabs and of universal transport media, such that we have not been able to establish daily testing so far. It's important to note that some colleagues have also elucidated further aspects of these dilemmas. One paper that is preprint, not yet peer-reviewed, but that I find particularly informative was by Larimore and colleagues. And in this paper, they answered an additional question, not just about the frequency of testing here, daily, 3 weeks, weekly, 14 days, and how much population level infectious burden is removed from the system, but also regarding the sensitivity of testing, a lower sensitivity versus a higher sensitivity test. They observed as not being in these models particularly consequential, actually, counterintuitively to me, that the turnaround time was much more important and the frequency much more important than necessarily the sensitivity, in part because those typically missed were missed in a short window of infectiousness early on, and then more likely much later when viral load may still be present, dead virus in the nose, but infectiousness not so much. And this was the subject of a very interesting New England Journal commentary recently, actually arguing that perhaps as a future research step, one should consider very rapid but rather low sensitivity tests, such as the new rapid antigen tests that have come out, because these tests may actually correspond in positive values more to a period of infectiousness and not have as much positivity. It's not really a false positive, but a non-infectious positive test result later in the period of natural history. This has much more to be elucidated, but there's initial evidence from the company BD, which makes the rapid antigen test, that viral cultures and the low sensitivity test actually correspond much better than viral cultures and the PCR testing. So to be determined whether our assumption that more sensitive is better is necessarily a good assumption. Another dilemma that I think we need to address in terms of future research is the upcoming flu issues. Although not common, it is possible to be co-infected with flu and COVID. And even moreover, in this particular sample from Northern California, with COVID and other respiratory pathogens. But one of the reasons I'm particularly concerned is that principal index that we're using at a population level for the control of COVID is the percent of tests positive. This is thought to be helpful because in areas that are under testing, if the percent of tests positive is high, one might argue about insufficient testing while also thinking about the number of deaths in combination as indicators of continuing transmission. However, in the setting of flu, of course, one may have a shift in the denominator where more people are going out and getting tests because they have respiratory symptoms. Those tests may be negative for COVID because they're attributable to flu or other pathogens. And so we might see an artificial decline in COVID test positivity that is not due to necessarily a decline in COVID, but simply an elevation of other respiratory pathogens. And so we might be confused between the dynamics and interplay between the two, despite the fact that percent positivity is being taken as a prominent index for determining when to open up different facilities and consider a state or county has met certain criteria for success. So I'll end on that note of future research themes. I'll thank the large number of people who contributed, especially Liz Chin, a wonderful PhD student, and Ben Hoon, also a wonderful PhD student who worked quite a bit on these models, and to many of the staff at the motels. Unfortunately, we did have one nurse who was infected with COVID and died. Thankfully, others have not been affected, although others have been infected. Others have not faced mortality from it among our group of workers. But thank you also for the opportunity to present. I'm happy to take some criticisms and further suggestions as we move forward in using these models.
Thank you so much. So if you're interested in asking a question, you can just put your name in the chat. You know, one of the questions I was going to have is where, as people are contemplating this, there was so much material, and I really appreciate the very careful way you kind of help demonstrate the constraints to build such a complex model. But I was interested in the real-time nature of this, And how unusual is that? Or is that something that is becoming increasingly common to really build these models and to provide feedback in real time? That seems like a unique aspect here.
Yes, I did observe that during this epidemic, more than in prior epidemics that I've experienced, the real-time nature of information was both a blessing and a curse. I would say it's been quite a blessing in terms of being able to get rapid feedback from a wide network of colleagues, and certainly the degree of information available in a preprint form prior to peer review has been both fascinating and damning. And I'm curious how you all are approaching this. medRxiv, I think, was quite a bit more esoteric than it is now. And so what does one do with that information in terms of weighing its importance? I certainly can't, I don't feel like I can read every paper that's related to COVID in that volume. I think it would be really impressive if anyone was efficient enough and still managed to do their regular job and could take in the sheer volume of papers that are going on here. So I liked the real-time meta-analyses that we were seeing, where people essentially split off into teams and used a team-based scientific approach to try to update meta-analyses in real time with regard to interventions. But no, I haven't seen this dynamic interplay between models and interventions quite so rapidly. One of the dilemmas, though, that I do see is in this rapid cycle, we may not allow interventions to play out sufficiently before condemning them. And so is it truly that an intervention is ineffective, or are we simply not seeing results on such a huge scale? And frankly, in settings like San Francisco, where we're relatively lucky because the incidence rate, of course, is much lower than in many other locations, how much to generalize what we're seeing in San Francisco motels to a colleague of mine in Texas who would like to learn from these experiences, but is in, incidence rates that are 100-fold what we're experiencing. It's not clear that we should so quickly condemn some of the interventions as being fully ineffective.
Thank you. We have Anne and Patrick.
So this is really fascinating, I have to say. I'm glad we're recording it because I want to go back and watch it again. I have two questions. One question is, the issue you raise about increased testing during because of the flu is something I've been worried about. And I just wonder whether you have strategies you've been thinking about in terms of maybe changes to your model for dealing with that kind of problem, because the increase in the frequency of testing is going to be unknown. I mean, we'll know how many more tests there are, I guess, but there are other factors which are causing changes in the frequency of testing. And, just seeing the results of testing and policy decisions based on that is really a fraught issue, as you say. I'll come back to my other question, but let me just say my other question. So my other question was, a lot of what you're doing or all of what you're doing is based on people, a particular portion of the population who are likely to be more susceptible to infection, maybe in general, and have other kinds of health problems. And I just wonder how you feel about generalizing results, whether there are any reasons that you would be concerned about generalizing the results that you have as a consequence.
Yes, thank you for those questions. So first, with regard to your flu question, I think we have at least three options. One is to make a more complex model where we simulate the dynamics of both COVID and flu. I'd say as an eager and ambitious graduate student, that would have been my reflex gut reaction right off the bat. And now, over time, I've become more conservative about how much uncertainties that would pose into the model and whether it would be really useful or not. I'm more ambivalent about. I'd say what I choose as potentially a second option is to break up the model into pieces about what I'm concerned about with regard to the flu, and flip the question around. What degree of flu incidence among these populations, and how much does it compare to prior seasons, would mess up the calculations that I'm interested in terms of frequency of COVID testing, in terms of how wrong I can be about who I isolate before I cause a motel outbreak. And in that way, I might get away with having less uncertainty in the results than having a full combined COVID and flu dynamic model, especially because flu transmission this year is going to be very interesting. Australia, in a piece of good news, seems to be reporting far less flu transmission as people are already, to a great extent, physically distanced. How much that's going to be true for us, I can't predict. So determining it based on last year or prior years may be quite challenging. So that's one option with flu. To complicate matters further, but to make it potentially also more positive, there are combined flu and COVID tests that are coming out. But problematic for our model is they have varied sensitivities as compared to existing COVID tests. And so should one trade off the information value gain from knowing whether a person is COVID positive, flu positive, both, or negative on both, for the sensitivity gain one has with just an isolated COVID test? And that's an interesting one that we could model out and see who gains and who loses and how much, or is the uncertainty so much that it kind of doesn't matter and just grab whatever test you can get. That we haven't done yet, but I think is worth doing. On to your second question, I am quite concerned about generalizability from a few different vantage points. First of all, we sort of forgot our first principles as primary care providers, and we're so, understandably, so in the COVID head, as we call it, that we forgot about all the other things our patients need. And the spike in opiate overdose deaths during this period, even within the motels, was alarming. And we had to recalibrate and remind ourselves that we're supposed to be comprehensive primary care providers and comprehensive providers of healthcare. And so in that setting, generalizability is certainly high. And thinking as an epidemiologist, if the mortality and dropout rates are enormous due to competing risks, what does that imply for generalizability of COVID frequency, for example? One can get much different results if simulating a nursing home, for instance, where a lot of people are not escaping through the fire escape, presumably. Where also presumably there's a lot less substance abuse and there's a lot of other dynamics going on. Also a highly susceptible, maybe more susceptible population. And so, yeah, I think it's important to contextualize. Also, you know, San Francisco is unique, the populations are unique, but also the politics are unique, the dynamic interplay between encampments that are formalized encampments that are informal, and these motels. The population is not just being shifted around based on public health workers saying, okay, this person is in quarantine or isolation and this person is shelter in place. They're also being shifted because of contracts between the mayor's office and motels, and a motel owner wants to open back up again or is complaining about these residents and wants to open up to the public, and the negotiations taking place between police and others affect, you know, how this operation occurs. And so it's hard to generalize. I imagine the experience in Los Angeles is profoundly different in a number of ways, not just limited to incidence rates.
Got time for Patrick's question. We just have 6 minutes.
Okay, I'll try to be quick. I've actually, my first question is relatively quick. It's a clarification question. I thought I heard at some point you said the Kermack and McKendrick differential equation could be solved, and I thought they couldn't, but it's been many days since my time in engineering school, so it's possible that now it can be solved. That would be wonderful news. But my other question is about your simulation model, and indeed, it's really impressive, the set of parameters that you have. Some of the results you present in percentage of simulation showing a particular result. So I assume that you do some kind of random sampling in a distribution of each parameter and do some run a large number of simulation. If that's the case, I'm actually impressed that the confidence interval are not wider than they are, because some of the parameters strike me as probably very hard to estimate. So my question was that is twofold. First, how did you estimate the parameters? Did you run your own meta-analysis to define the distribution of these parameters? And second, if the confidence interval are relatively small, is it because the results are driven by a few parameters that are somewhat better known than some of the others?
Yeah, thank you. I should have clarified, and thank you for catching me, that Kermack-McKendrick would be solvable in a steady state solution, so not particularly helpful for our situation, but thank you for that. In the second case, yes, repeated sampling, usually not from a meta-analysis that we conducted per se, but rather that we would find in the literature. And in that sense, what was interesting to us is that there were a few key parameters in the sensitivity analysis that were driving a lot of the results. Two of the keys were those of interest to us, testing frequency and turnaround time. But the other two that were of interest to us was the degree of infectiousness of late versus early stage infection. We've only very recently gotten some further viral culture information that helps narrow those down quite substantially. And those are from very careful studies of people enrolled in some trial control groups of a few trials and who were observed in inpatient settings. And then the second was the proportion of people who are asymptomatic, which initially has been widely varied. And again, through some careful sampling, it started to narrow down. Although again, this week, perhaps we found that our meta-analyses are too narrow and we may have to go back to a wider distribution of understanding. But thank you for that. Yeah.
So we've still got time for another question. A quick question.
Hi, Dr. Basu. Thank you very much for the presentation. Just wondering if I don't know if you mentioned this or if I missed it, have you also tried to implement maybe a micro simulation model given the heterogeneity of the population to see if that might yield better insights?
Yes, thank you. In some of the simulations we have, and in particular with the purpose in mind of understanding not just how much heterogeneity there may be in the population, but also whether different ways that we can triage people up front may help us reduce the susceptibility of the population. A good chunk of the population has heart disease or diabetes or asthma. A good chunk of the population are older adults. And there remains debate about whether the most sophisticated approach to putting people in shelter in place, either by congregating those people together in more carefully isolated facilities, as one group would have, or conversely, to ensure that those people are not together and that they're effectively separated more with more healthier young people in between them, which approach might be better or neither, or whether there's simply too much uncertainty. And so in that setting, we're building a micro simulation, but as you know, that takes quite a bit more time. And to estimate the parameters well is pretty challenging at the moment.
Thank you.
Well, I just want to thank you, Dr. Basu. This was really an interesting presentation. I think we learned so much about really looking into the black boxes of some of these models, and I think that's so incredibly important to us. I'm going to ask people to remember to sign in. I've been requested to amplify that message. As well, the students who are going to meet with you, Dr. Basu, afterwards at 1:30, please stay on, and the rest of us can log off by 1:30. Thanks so much.
Thank you.
All right, excellent. Great presentation, Dr. Basu. We're just waiting for a few more people to sign out. And then if they don't sign out, I'll go ahead and remove them before we begin the pro seminar.
I'm not going to join the pro seminar, but thank you again. I just want to really let you know how great it was to have you here and how much I know everyone appreciated your presentation. So thank you.
Delighted. And just for my own timing, how long do we have for the pro seminar?
So the pro seminar typically will last about 30 minutes, but if students don't have a lot of questions, it might take less time. It really depends. And I'm actually going to make you the host now. Let me go ahead and stop the recording.